So good evening, folks. Today I'll be talking on this 12th COVID update. So I would say this would be my smallest update. So I'm covering two articles on ARDS which has come recently. So this I'm talking on 30th April. So those two papers are pretty much photocopy of each other. So one is come from Gattinoni. The second paper came in JAMA by Marini and Gattinoni together. So both, if you read both the papers, they're almost like photocopy of each other. So there's not much difference at all. So there's only one thing that they've emphasized in Marini's paper, which I'll talk in one slide. So this would be my shortest update. Maybe it should take less than 10 minutes. So this is the paper which came on 14th April in intensive care medicine. COVID-19 pneumonia. So different respiratory treatments for different phenotypes. So came by Gattinoni. So in this paper, they have looked at the Italian data, and what they have subscribed to is 50% of the patients out of 150 patients in Italy that they have looked at, they had normal compliance of the lungs. So these two papers are mainly to understand the type of ARDS that has prevailed has been distinctly very different to conventional ARDS we deal with. So this is the high point of these two papers. And as you see, 50% of the so-called ARDS who have been treated had a normal compliance, which is very different. And it has been mentioned that they do have silent hypoxemia, which means not necessarily they would be symptomatic to a point that they are feeling dyspneic or they're having severe cough or they're feeling short of breath. So, but when they would check their oxygen levels, it would be low or saturations would be low. And they found that they tend to have lower CO2. Maybe they were mildly tachypneic and washing out their CO2. So this is what they found. And there was another group with normal compliance who were dyspneic and where the CO2 either remained normal or was slightly higher. So these were the two distinct prototypes they saw in these 50% of the patients with normal compliance. And the authors do mention that these are the distinct group of patients who conclusively did not benefit from prone ventilation. Some of them were prone and some of them were not. But the benefit was questionable in these patients. So, and the authors do mention the outcome of ARDS, COVID-19 ARDS, depended on 3 to 4 factors. So, one of the factor the authors claim is that it depends on the type of response the patient shows to the infection. That is one, and the severity of the infection itself. So, that also defines. And another important factor is the lag time between the infection and the patient seeking medical attention. So, that we all understand has a huge bearing on determining the outcome. And the third most important entity is their response to the ventilation that you provide or the ventilatory parameters that you would set. So that also had a bearing on determining the severity. And the last but not the least is obviously the age, physiological reserves of the patient and comorbidities. So we understand most deaths have happened above the age of 60, and even in the patients above 60, patients with lot more comorbids had a higher mortality. So these are the four factors which we all should bear in mind, that the response really dependent on individual's response to the infection, severity of infection, response to ventilation, lag time between the admission, between seeking medical treatment and the onset of symptoms, and their physiological reserves and comorbidities. So in this paper, Gattinoni elucidates on two distinct types of ARDS called L type and H type. So the L type ARDS is with normal compliance, where they have a low elastance. They can have normal or high compliance. So most of them had a compliance up to 50 or more than 50. And here the author suggests that they would benefit from a normal tidal volumes or maybe even a little liberal tidal volumes of 8 to 9 ml. And they provided a PEEP of 8. I'll tell you the rationale as to why they believe the little higher PEEP may be helpful in these patients. So the H type had high elastance and low compliance. So this is a typical ARDS which we normally deal with, the conventional type of ARDS where there are recruitable alveoli. And here obviously you would follow low tidal volume, targeting plateau pressures less than 30 and optimizing or titrating the PEEP. And what they found is in the L type had a lung weight was lower because they did not have flooding of the alveoli. So there was no inflammatory exudate flooding the alveoli, and there was no recruitable alveoli, which means the lung was dry. So that's why it was not heavy. But the H type is a typical ARDS where you would see a lot of inflammatory exudates or flooding into the alveoli. So there's a lot of fluid congestion in the lung. So it's a non-cardiogenic pulmonary edema. So they had a higher weight, more than 1.5 kg was the lung weight. And as I said, the L type, they did not have a recruitable alveoli. So because it was a dry lung, so they had a ground glass opacities because of the inflammation that may have set in, but they did not have flooding of alveoli, so low recruitability. But the H type, which is a conventional ARDS we all deal with, had a high recruitability. So this was the two distinct types that they really dwelled into detail in these two papers. So, and the pathognomonic feature of L type, what the authors suggest is they have a low VP, ventilation perfusion ratio. So what it means is there is no hypoxic vasoconstriction that happens, and there is a ventilation perfusion mismatch. So there is no effective oxygenation that is happening of the ventilated area because of the ventilation perfusion mismatch. And what this essentially leads to is, in the L type they have a increased negative intrathoracic pressure because they generate good tidal volumes or more tidal volumes, and they generate negative intrathoracic pressure. Along with this, there may be increased lung permeability that may set in, and these two distinctly cause patient induced self-inflicted lung injury. So this P-SILI or patient self-inflicted lung injury was typically found in L type because of their huge tidal volumes that they generate, along with lung permeability, leading to worsening sort of a hypoxemia that set in. And the predominant pathognomonic is the VP mismatch. So there is a reduced ventilation perfusion, and there is not effective oxygenation of the pulmonary venous circulation that is happening. And there is no hypoxic vasoconstriction of the pulmonary circulation. So the CT findings in L type is typically like this. So you have this peripherally placed ground glass opacities. So you would agree that that conventional or typical ARDS we see is predominantly baby lungs are spared, and more of consolidation or the opacities you would see more in the basal regions. But here you see more peripherally placed ground glass opacities rather than a proper consolidative or alveolar based opacities in the basal region. So that was distinctly different in the L type. This is what the authors try to highlight. So in the H type, the main pathognomonic feature is there is a right to left shunt. So basically the blood is not participating in the gas exchange. And the H type is a typical conventional ARDS where you see extensive consolidation changes predominantly involving the basal or the mid-basal region. And you see the baby lungs are spared, the apical aspects are spared. And that is not the case in L type where you see there is more of peripherally placed ground glass opacities. So the authors do suggest for L type because they are generating huge tidal volumes, but they are hypoxemic because there is no gas exchange or there is no oxygenation of the blood that is happening in the pulmonary venous circulation. So having said that, they would benefit from high flow oxygen or NIV, and authors do suggest that the first indication for us to understand, which I felt this is important. This is a surrogate marker where you would ascertain whether they are at a risk for developing patient self-inflicted lung injury is when their work of breathing increases when they are on high flow oxygen. That is one. And this work of breathing coupled with the surrogate marker where you see huge swings in the CVP trace. If these patients have a CVC line set put in, so if you see a sort of pulsus paradox, a sort of a huge swing in the CVP trace or CVC, that may be an indicator that these patients are heading into PCD or the patient self-inflicted lung injury, and that is the time the suggestion is made we have to intervene, and they may need intubation and sedation to reduce their work of breathing to curtail the PCD that may be ensuing. And even here the author suggests that high PEEP, because once you find there is a huge swing in the CVP trace or increased work of breathing, the higher PEEP has an ability to reduce PCD by reducing the uh, changes in the pleural pressure. So by reducing the changes in the pleural pressure, it may have some benefit in reducing the PCD. So this is what the author subscribes. So, but the ideal way to reduce PCD is to monitor esophageal pressure. So, if there is an increase in the esophageal pressure from 5 to 10 to more than 15, so that is a clear indication that these patients are at a higher risk of PCD. So, which means they may need a higher PEEP or they may need intervention in the form of intubation and sedation and relaxation and so on and so forth. So, I think this is an important concept that authors highlight. So, it is important once we have a COVID-19 patient with a L-type ARDS, so it's important to keep an eye on the work of breathing and to look at the huge swings in the CP, which may be indicative that they may be heading into PCL. And the ways to curtail PCL is maybe to keep a little higher PEEP so that we reduce the changes in the pleural pressure and curtail the transpulmonary pressure and the ensuing injury that follows. But the ideal is to have esophageal pressure, which may not be feasible in the current pandemic in our country. So, and the authors also suggest these patients, since they do not have recruitable alveoli, so they may not really benefit hugely from proning, because proning really benefits when you have a ARDS of this nature where predominantly basal regions are consolidated and you are able to recruit. You have a recruitable alveoli. Proning helps you in recruiting the basal alveoli much effectively. Since this pathology is absent in L type, so proning in these early proning definitely may not be helpful, but proning may be beneficial if this L type is progressing into H type in the later stages. So I think this is just a 2-page article. How much ever you read, this is the essence of this article. So this is the Marinis paper which came in JAMA in 24th. As I said, this is exactly photocopy of the Gattinoni paper that came in intensive care medicine. The only thing this Marinis paper highlights in the L type is they say in L type, because there is no flooding of the alveoli, and it is more of ventilation perfusion mismatch that is happening, which means there is no pulmonary hypoxic vasoconstriction and there is no oxygenation of the pulmonary venous. So in addition to this, they highlight there is microthrombi formation in the pulmonary circulation, which may further worsen your ventilation perfusion mismatch, and it may further worsen the hypoxemia. So this is one aspect this paper highlights, that there is in L type predominantly along with VP mismatch and absence of pulmonary hypoxic vasoconstriction and hypoxemia that is setting. They, because of this, and the lungs are not flooded, so the hypothesis is that they do have this microthrombi which further worsens hypoxemia. So to this effect, the suggestions are made that in L type, the fluid management has to be little more optimal to maintain euvolemia and not dry out the lungs as what we conventionally do in H type. And to an extent, the protocols have been devised where these patients may benefit from systemic anticoagulation to prevent this microthrombi formation. So that is the only addition that Marini's paper elucidates, in addition to whatever the Gattinoni paper. So, and this paper is co-authored by Gattinoni also. So that's the end of these two papers, friends. I think there's not much because this is a single page paper and the Gattinoni paper is a 2-page manuscript. So this is the core essence of these two papers, where they have highlighted that there are two distinct variants that occur and the management may differ. In H type, you may want to follow your conventional ARDS, keep them dry and recruit them with high PEEP and attain lower tidal volumes to get your plateau pressures less than 30. But in the L type, so the euvolemic status is what you maintain and have a high lower threshold to anticoagulate, because there may be a potential risk of microthrombi formation, and and measures to avoid PCL by maintaining little higher PEEP so that you would reduce the changes in the pleural pressure, and trying to look at the swing in the CVP trace and looking at the work of breathing, which may be an early indicator of developing PCD. So this is all is the essence of these two papers. And I think this paper also talks about cytokine storm that prevails in L type ARDS, and the measures that one may have to consider to mitigate or curtail this cytokine storm. So thank you very much. So I would end with this cartoon, which I'm sure you have seen in WhatsApp, and another cartoon. So thank you very much. So if you have any, if you wish to rehear to this lecture, you can visit my website www.drpradeeprangappa.com. If you have any queries or questions, you can write to me, and you would hear from me. Thank you very much.